10 o'clock Eastern Time, and I'd like to get started. My name is David Bishai. I'm at Johns Hopkins University. I'm the former president of the International Health Economics Association, and this is our session on the impact of COVID-19 information and policies on risk perceptions, preventive behaviors, and pro-social behavior. This session was assembled under the sponsorship of the International Health Economics Association, and I have to give credit to our executive director, Di McIntyre, for helping to get us organized. She does this every year, and it's always been an excellent session for us to get together. We will be having 4 presentations. I'll be introducing the panelists one by one. Each panelist will speak for 20 minutes, sharing their own screens and slides. After 20 minutes, we have discussants, and I will be introducing the discussants. The presenter will take down their slides, discussants will put up their slides, and we'll hear the discussants' comments. As attendees, you have a Q&A box available to you to write in questions as they come to you. We will be entertaining the questions of clarification at the end of each presentation, and then we'll have about 15 minutes at the end for group discussion. If you have been finished with your presentation as an author or discussant and you see questions in the question box, you can answer them with your fingers, as well as with the audio when we come back to group discussion. But I'd like to give that Q&A box full use today. The attendees, I'm glad you're here. Presentations, I'm glad you're here. On a personal note, it's nice, I will tell all of you in the audience that you actually have a policymaker in the room today. I've just taken a job as a local health officer here in Maryland. So it's my job starting tomorrow to control COVID-19 in my county. I have 250,000 people not wearing masks as much as they should, all desperate to get the COVID vaccine or not. And so I'm taking notes. I am going to put into practice what you tell me today in my new job as a health officer. So you will have instant policy translation on my watch. All right, let's get started. Our first presenter is Dr. Gabriella Conti, and why don't you start sharing your screen, Gabriella? She's from the University College of London, and her talk is on the perceived costs and benefits of COVID-19 social distancing measures and compliance behaviors, evidence from subjective expectations. The floor is yours.
Yeah, can you see the screen?
Yes.
Yeah, okay, so thanks very much for having us. This is joint work with Pamela Giustinelli, who is also here. We're really excited about it. It's the first time that we present, and we look forward for the comments. And if you have more, please do send them by email. So I think there is not much need for motivation for this kind of work. We're all aware of the terrible consequences that the pandemic has had on us and the restrictions which have come upon our lives. And this restriction has varied both within and across countries, and people have displayed different degrees of compliance. So I'm sure you will agree with me that understanding the perceived cost and benefits of compliance is of fundamental importance. And we try to shed some light on this issue in this paper by using recent advances in survey elicitation and econometric analysis of probabilistic expectations. So in particular, what do we do? So we study perception of risk and benefits of compliance to COVID-19 social distancing rules in the UK in May 2020. UK has been in lockdown. It was in lockdown since March 23rd, 2020, and then lockdown ended in June, and then now it started all over again. So quite a bad case in the world. And what we do is that we survey a representative online sample, more than 1,000 individuals, and we elicit both objective probabilities of compliance behaviors and of different outcomes. For example, contracting coronavirus, unconditional and conditional on alternative compliance behaviors. We use this to estimate a simple model of compliance behavior with uncertain consequences to quantify the trade-offs individuals face and the monetary compensation required to comply, so to be essentially socially isolated. So methodologically, we build on the survey expectations literature. So there has been a large and growing literature. Pamela has contributed a lot to this literature, and there have been many review papers. I don't have the time to go through. And these survey expectations can be used to estimate treatment effects, for modeling choice under uncertainty, to study how people learn, especially in reaction to information. And there have also been a few papers, and I'm listing some of them here. I don't have time to go through them in details, which have elicited survey expectations in the context of the COVID-19 pandemic. So what we do in more details, as I mentioned, we collect data from a representative sample of adults living in the UK between 3 and 10 May 2020. We have 1,132 individuals. We use an online platform called Prolific Academic, which has been shown to have very reliable respondents. It's been used also now in economics a fair bit, also in papers which are either published or forthcoming in good journals. We have a very rich survey. We've asked these individuals a lot of information about themselves, their health. We have very nice sections on their knowledge of the corona. I think this was May, their experience, the behaviors, and in particular, we have asked a very large battery of expectations and background characteristics. And today we use data in particular from these last two sections, but in ongoing work and in future work, we will use more comprehensively all the rich data that we have collected. So what happened in England? England, as I mentioned at the beginning, tops really the chart at the world level for the number of cases and the number of deaths per 1,000. And it was one of the countries in Europe which started later a full lockdown. So Boris Johnson only announced it on television the evening of 23rd March 2020 after a lot of pressure after having delayed for a long time. And guess what? Like many other countries, the lockdown lasted until the summer. In the summer, there was reopening, and now 3/4 of UK are back in lockdown again. So I'm currently locked down in London. So how we introduce this section, so we have this nice introductory screen where we said, well, as you know, now there are these rules on social distancing, which came in effect on the 23rd of March, and they can be summarized as stay at home. And actually, there is some variation in the rules because some particular categories of individuals, for example, those vulnerable because of health conditions, essentially could never leave home for 12 weeks at the beginning. Those self-isolated could not leave home for 1 or 2 weeks, but the key workers could leave home just to work, but otherwise could not leave, indiscriminately. So there were some variation in the rules, and this survey explained very clearly what are these rules. So just a few characteristics about our sample. So as I mentioned, it's representative by age, is representative by gender, is representative by ethnicity. We have quite a few people with education of undergraduate degree or postgraduate degree. We have 15% of the sample on low income. Most of them live in England, and these are different categories which are subject to different rules. The vulnerable being subject to the more stringent ones because essentially those could never leave home for 12 weeks, starting the 23rd of March. So what do we do here? We don't observe in this setting the actual choices at the time of the survey, so we elicit the probability that individuals will perform a certain action, certain compliance behavior over the next 4 weeks. And so this is our elicitation scenario, and we give them the option of choosing 4 possible actions. The one is you never leave home. The second one is you strictly follow all the rules that apply to you. So for those vulnerables, those rules would be essentially you never leave home. Otherwise, you only leave for the grocery, for essential work, for exercise. Third one is like you generally comply, but there is a little bit of slack. You go out, I don't know, just to have a walk more than once. And then the fourth one is essentially you don't comply, you just get on with your life as you used to, and then bye-bye rules. And as you see, we essentially force them, the sum of these choices, to sum up to 100. And these are clickable sliders that our responders have to click. So this is plotting the compliance probability as percent chance for the 4 different actions for which we elicit these percent chances. And what we see is that there is a mass essentially around 0 mostly for never leave home, general compliance and non-compliance, but there is also a fair bit of variation. And for the action of strict compliance, there is much more variation, it's much more spread. There are spikes as usual, but there are less spikes than usual because of this clickable slider that we use. So just looking at the compliance probabilities during different moments of the distribution. So what we see is that the highest mean is for strict compliance, so it's 54% chance. Individuals say on average they will strictly comply, but there are good percent chances also for the other groups, and the standard deviation is quite wide. So there is quite a lot of variation among our respondents on the probabilities of compliance that they tell us. Now, in addition to eliciting the probability of compliance, we also elicit perceptions of risks related to the coronavirus. And we start eliciting unconditional perceptions of risk. And in particular, we elicit the following percent chances. The percent chance of contracting corona, either with or without symptoms, and we always use an horizon of 4 weeks. Percent chance of developing no symptoms, at most mild, severe to acute symptoms, and this one they have to sum to 100%. Percent chance of not finding space in a hospital with ICU in case you developed acute symptoms. Percent chance of essentially dying if contracted coronavirus, and we also elicit an expected fine if you were caught transgressing. So all our elicitation scenarios look like this, where we have the sentence with the question and we have our clickable slider showing 0 to 100. So how do this look like? So on average, people expect, say, 25% probability of contracting corona, and you see that they expect there is a 44% chance of contracting corona and displaying mild COVID symptoms, 25% chance of dying if contracting corona, and their expected fine if caught transgressing, which will happen if they generally comply or they strictly comply, is £137. So after this, of course, these perceptions of risks can vary depending on which action to take. So we also elicit them, or better re-elicit them, conditional on the various compliance behavior they might take. And so we elicit the percent chance of contracting coronavirus in these 4 different scenarios: if you never leave home, if you comply strictly, if you comply generally, or if you don't comply. We do not explicitly elicit this percent chance of developing acute symptoms, not finding space, COVID-19 being fatal, given that they are conditional on contracting corona, and we use the fact that we re-elicit that. Then we elicit for their perceived risks. So the percent chance of infecting someone not living with you, and the percent chance of infecting someone living with you. The percent chance of being caught transgressing, which of course can only happen if you generally comply or if you don't comply, and then if expected fine if caught transgressing. So this is an example scenario for the first one. So we're releasing what are the chances you will contract coronavirus over the next 4 weeks if you were to take the action. And these are the 4 actions, the 4 different degrees of compliance that I mentioned before. In addition to eliciting perceived risks, we also elicit perceived benefits from different compliance behavior. In particular, these are benefits of leaving home. So what are the perceived benefits of leaving home? So not becoming unhappy or depressed, which was one of the main justifications usually given by individuals for not complying to rules, not gaining weight or becoming unfit, not worsening relationships with family, friends, and colleagues, not losing a job or falling behind with exams and studying, and not running out of money. Now, how the people perceives these different risks and benefits across the different actions. So what we are displaying here are means of within person differences across actions. So what does it mean? That people on average perceive a 44% higher risk of contracting coronavirus if they were doing action 4, which is not complying at all, versus action 1, which is the probability of staying at home. And you see that across all actions, there is this gradient. So the people perceive a higher risk from not complying at all versus staying at home. And second one being generally complying versus not leaving home, and strictly complying versus not leaving at home. And this is true across all risks. At the same time, if we look at the perceived benefits of leaving home, there is on the same gradients, which is particularly pronounced for not becoming unhappy or depressed and not gaining weight or becoming unfit. So people perceived higher percent chance of not becoming unhappy or depressed, not complying at all versus leaving, never leaving home, generally comply versus leaving home, strictly comply versus leaving home. You see that there is a little bit less difference across the various actions for the relationship, losing jobs, and running out of money, probably because people who were like key workers and they had to go out of the house to work, they could still go out of the house to work. So what do we do now? We develop a simple framework to model compliance behavior. Now, if we observed the data on actual choices, which is what usually happens, like if you observe data on actual compliance behavior, we could just use a standard subjective expected utility framework where the individual maximizes the SEU and chooses an action dij is equal to 1 if person I chooses action j from a choice set. So this is the standard framework. One important thing to notice is that the subjective expected utility is made of these two components. So these differences in utilities of consequence k versus not k, so catching corona versus not, and the subjective probability of consequence k if action j is taken. Importantly, the unobserved heterogeneity term in this particular framework is known to the individual and unknown to the econometrician. However, in our setting, we don't observe the actual choices. We elicit their planned behavior in terms of compliance. And so we have an ex-ante decision problem. So we are eliciting their planned behavior, their planned compliance behavior at the time of the survey. And so the choice problem of person I at the time of the survey before the actual choice, what is it? Is this choice probability that we elicit, which is the person I subjective probability of choosing behavior J in the next 4 weeks, which is the probability that the SEU of behavior J tilde is higher than the SEU of another behavior J. Another important aspect in this particular framework is that here the unobserved components can be separated into two components where one is known to the individual but unknown to the econometrician, like in the standard framework where we observe the choice, but this XI component is unknown to both of them because the individual has some additional uncertainty which will be resolved at the time of the choice. Now, the nice thing about this framework is that if we assume that the unobservable components are IID type 1 extreme values, so we can invert the choice probabilities and have a nice linear analytical form that can be easily estimated. So here what we have as dependent variable, we have the difference in the log of probability of action J, so like not complying versus our reference, which is never leave home, as a function of the difference in risks and benefits of that particular action J versus never leave at home. And we have seen that there is a lot of variation both across actions within individuals and across individuals. So we have a lot of variation to estimate this model. And we estimate by least squares. So these are our benchmark estimates. So what we see here we have all our betas, which are these utilities associated with either the risks of leaving home and the benefits of leaving home. So now, given that this is a framework in terms of utilities, so we can't really interpret directly these estimates, we can just interpret them in relative terms. So for example, what we see is that this utility of not finding space in an intensive care unit in a hospital, in case you have caught COVID, is the same like weights as the utility of not becoming unhappy and depressed. And at the same time, we can compare these two, and we can see that the utility of infecting people living with the respondent is comparable to the one of infecting people not living with the respondent. However, now what we can do is that, given that, remember, we also asked about the expected fine conditional on transgressing, we can also use this expected fine coefficient to transform these utilities into monetary terms. And this is what we do next. So why this is a useful exercise? It's a useful exercise for two reasons. One, because it allows us to give a monetary value, which is easier to interpret. And then two, because as it happened, the English government is actually paying people, or at least starting paying people, to self-isolate, to comply, and to stay at home under certain circumstances. So we can inform that. So how do we proceed in order to go from the utils to this quantitative, to this monetary terms? So we use this condition, which is given in a paper by Adeline de Lavant, and essentially we can compute the willingness to pay or the compensation to change, ceteris paribus, the chance of a certain outcome, which are the risks and benefits that we saw before, by a certain percentage point. So here in this
2 minutes. 2 minutes.
Yeah, I'm almost done. Yeah, thank you. So here we've used as a benchmark, we've used a 5 percentage point. So essentially what we do is that we divide the coefficient of each outcome by the coefficient of the fine, multiply by 5 percentage points, and this is the result that we got. So how do we interpret this? So for example, take this number here, which is on the probability of dying after having contracting coronavirus. So this says that the individual is willing to pay £11 to reduce the probability of dying after having contracting coronavirus by 5 percentage points in the next 4 weeks. At the same time, this number here, 7.5, is the compensation needed to increase the chance of being unhappy or depressed by 5 percentage points in the next 4 weeks. And then, of course, this is just change one outcome at a time. In the future, we're going to look at different combinations of outcome to have a more comprehensive set of quantitative estimates for how much you need to pay individuals to stay at home. But meanwhile, another nice thing that we've done in our survey is essentially we've asked individuals, what is the amount which will make you 100% compliant? So we're asking them directly to elicit the monetary value to stay them, to never leave home. And the median amount that they have told us is 100. At the same time, as I mentioned, the English government since September started a pilot scheme in poor areas of England, where they are essentially paying people low income when they have to self-isolate, either because they have symptoms or because they've been told by the test and trace system to self-isolate, and they're paying them £130 for 10 days. So this will be looking just individuals with low income unable to work. And in future work, we can look at how this willingness to pay and the compensation varies across people with different characteristics. So this is what we had so far, where there's a lot of work that we're doing. As I say, this is just the first time that we present this work. So we're going to test the robustness of results using LED estimator. Then we can look at a lot of heterogeneity. We have a very rich survey. So we can look at how the utils changes the function of the covariates. We can decompose how much of the choices the individual make are driven by beliefs and how much they're driven by preferences. As I mentioned at the beginning, we have collected data on the knowledge and experience of coronavirus, so we can study the formation of these beliefs that people have on risks and benefits, which I think is something really nice. We have also a subsample not included here, where we have asked, instead of single point probability, we've asked a range probability, so what is like minimum and maximum probability of catching coronavirus, and that's going to be useful to look at deep uncertainty as expressed, by the gap between the mean and the max. And also we have follow-ups. So we carried out a follow-up at the end of May, when we can actually look at the realization actual choices and compare them with the choices that we have elicited at the time of survey. We also did the randomized intervention showing a Q about of a very visible breach of rules, which was done by the Prime Minister aide, Dominic Cummings. And given that now we're back in lockdown, essentially back to where we were in May, we're gonna field another survey and see how people's beliefs have changed and what we can learn from that. So that was for us. Thank you very much.
Thank you, Gabriella. Why don't we have you stop sharing your screen and we'll move over to our discussant, Sue Horton, who will start sharing her screen. For those of you in attendance, you should be seeing a Q&A box, and I am glad to see some of the questions coming to the Q&A box. After Sue's discussion, we will be taking questions of clarification and then coming together to address all of the questions together as a group. Authors are totally encouraged to use the keyboard if they want to address some of the questions using the keyboard, but we will have time for an audio-based discussion. So turning it over to Sue Horton, who's addressing us from the University of Waterloo on her comments on the discussion. The floor is yours. We don't have audio yet, Sue. Can we get your audio?
Okay, apologies. With the shared screen, I couldn't unmute. So thank you for inviting me to comment on this interesting paper. And it's a bit of a change of pace for me because most of my work on COVID and on other health is to do with the low and middle income countries. But recently I took on a theme lead for the economics and policy component of the CAN COVID organization in Canada, which aims to provide up-to-date information on COVID policy and on research that's going on in Canada. So it was very interesting to see this paper and as a result. Okay, so using a kind of public health approach, I'm going to mention the strengths and limitations of the paper. So the strengths, obviously, the UK, and here I'm full disclosure, I was born in the UK, is doing an absolutely terrible job compared to many of the other high-income countries, and in consequences, really severe outcomes in terms of particularly mortality rates. So definitely very interesting to look at the UK. And, as you know, the UK and the US, by their own citizens, were ranked very poorly in terms of the COVID response. So I won't go on at length about Canada, which I think is actually doing a better job. But anyway, nevertheless, so in terms of the limitations, in COVID terms, these data are really old. I mean, it seems crazy to be talking about data 7 months old as now being really old. But in my work with the CAN COVID for the, providing information to the Canadian government, stuff that was happening in May is almost irrelevant by now, unless, of course, you can use it to elicit general tendencies. And I assume that that's what Dr. Conti and her colleagues are going to now do with these comparisons, for example, cross comparisons amongst individuals within the sample, which were not presented, and also the overtime comparisons. I'd never heard of Prolific before, and I guess it's a panel of prolific survey takers who are willing to work for $6.50 an hour. So this may be representative in terms of age and work status of the general population, but maybe not in some other respects. I mean, anyone who's willing to work for $6.50 an hour is probably not representative of the general population. Is the sample adequately powered? I've given you some numbers there. I mean, yes, 1,000 is a lot if you can go across the whole sample, but if only 1/3 of your sample is actually working and you're asking a question about how are you fearing about losing your job, you've lost a lot of power there. A couple of other issues. Obviously, some of the questions are only relevant to the subsets. People are highly unlikely to get depressed if they can't leave home, if they're a key worker who has to leave home. So some of these have to be interpreted quite carefully, I think. And also the probabilities for individuals, as of course, Gabriella elicited, varies very substantially by individuals. And I think you can see that in some of their results. So, and I will make a couple of remarks about willingness to pay more generally. I mean, I'm an economist. And of course, I think that money and incentives are really important. but I think we're approaching the limits of economics in terms of COVID in a time when there is so much uncertainty and the risks are so high and so unknown and behavior changes are so drastic. So I thought there were some really interesting results. For example, in slide 24, it shows you that people who fear a higher probability of dying are likely to behave more strictly in their behavior, which we would totally expect. But and this is kind of paradoxical, people who think that if there's a higher probability of getting the disease are likely to behave less strictly, if I interpret the slides correctly. Okay, and full disclosure, I only got the slide set 3 days ago, and I have not seen the paper, so I may be misinterpreting things, and if so, I apologize. The fines have the expected effect. You know, the higher the fine, there is a small effect on people behaving more strictly, but people who fear have a higher probability of not getting depressed are less likely to strictly comply. And I think the two middle points are telling us not something about individual behavior, but about subgroups of individuals within the data set. That I think my own interpretation is that it's young people who do not feel that they're very likely to get the disease and are also likely to behave less strictly and less comply with the rules. And similarly, you know, young people who feel a stronger need to be very social, you know, perhaps because they're not, don't have a partner, they don't have families, they feel the need to go out much more, and they fear getting depressed by staying at home, and that's associated with less strict compliance. So I think that's where it might be useful in this paper to tease out the behavior amongst different groups within the data set, of course, subject to the constraint that the samples then become quite small. So I'm going to finish up with 3 very small, quick slides talking about why I, as an economist, am less thinking about willingness to pay in these special circumstances. So how relevant is willingness to pay? You probably all saw this about Kim Kardashian, you know, who is so humbled and blessed by having all her friends isolate for 2 weeks and take them off to an island to party, totally not obeying any of the rules at that point. But not to be out, I mean, the shame that she received of this obviously wasn't enough, because her sister or cousin or whoever it is subsequently held a Halloween birthday party for her 25th birthday and gave people lateral flow tests as they came into the party. And then as long as they didn't put it on social media, you know, they were able to party to their heart's content. And I think this comes to the shame factor. And that's really relevant. Gabriella noted Dominic Cummings getting not fired for shameless behavior. And I will contrast that more recently in Canada. We had at least 3 politicians who lost their jobs because they went off on trips, you know, over the holidays, despite not following government rules on this. So, and my last couple of slides are to do with vote of vaccine. Well, this one's to do with vaccine hesitancy, which I think is correlated with the behaviors to do with staying at home, you know, and I think some of the same factors affect them both. Turns out in Canada and the US, political affiliation is really strong. I mean, I'm sure you've seen this in the paper that Republicans are much less likely to comply than Democrats in the US. And I was quite surprised to see the same trend, that the more conservative voters in Canada likewise are less afraid of COVID than the more liberal ones. And that's correlated with likelihood of getting the vaccine. I haven't seen anything for the UK, but I'll bet it's the same. I was quite surprised to see this. And I think that's a deeper affiliation than how much money you're going to get. I mean, I find it hard to believe actually that anyone who's willing to, for £100, is willing to reduce the risk of catching COVID from 100% to 0%. So, you know, I found that hard to interpret. Okay, and here's my last slide. I've seen a really nice slide, and I couldn't find it again for this presentation, which correlated trust in government with death rate. But if you look along the very last line here, at 40 days, you can see there are factors that are positively associated with a higher death rate, like higher income inequality, and trust in the state institution is the complete polar opposite. The more you trust the state institutions, the lower the death rate. And I think, the information about individual behavior and willingness to pay of individuals, it matters, but at the same time, we really have to take cognizance of the social forces because this is a circumstance where the social transcends the individual. Okay, and thanks again for the opportunity. Very interesting work. Thank you.
Thank you, Susan.
Great. Thanks, Sue. And I'm looking at the question and answer box to see if there are questions of clarification. I do not see any. If you would like to raise your hand or indicate that you have a question of clarification or put it into the question and answer box, that would be great. Sue, could you stop sharing your screen, and we're going to be turning over to the next presenter.
Okay, I have stopped sharing, so I don't know.
Maybe Gretchen can help stop sharing, and then we'll move on. And for our audience, you should be able to see the Q&A box for your questions of clarification. And Gabrielle has already started to answer them there, but we will come back for an audio-based discussion. Gabrielle, I will be asking whether the internality is bigger than the externality and whether or not this is incentive compatible behavior that you've elicited, but we'll get to that. I see some questions about the slides and recording this. This is being recorded, but ASSA's policies will govern it. I'm going to see if we can. So do you see a share screen button at the bottom? Because you do need to stop sharing.
I think she stopped sharing.
She did great. Okay, so
she did stop sharing. You can move on to the next presentation.
Great. So Nicholas, can you load your slides? Great. So Nicholas Stacy will be presenting is an end in sight, vaccine availability, risk perceptions, and preventive behavior during the COVID-19 pandemic. Nicholas is coming to us from the London School of Economics and University of Witwatersrand. You're on.
Great. Hi, everyone. So the title of our paper is an end in sight, vaccine availability, risk perceptions, and preventive behavior during the COVID-19 pandemic. So the motivation for this paper essentially this sort of operating premise that once we have a COVID vaccine and it's been sort of rolled out sufficiently, that the pandemic will essentially be over. And we see, sort of depictions of this through this Economist cover where the vaccine is sort of being depicted as the lights at the end of the tunnel that we're all sort of moving towards. The challenge at the moment is, though, that the timeframes for when mass COVID vaccination will happen are currently highly uncertain. So through 2020, there was a lot of uncertainty that was arising, particularly from the vaccine development process and the trialing. But we're now moving into a phase where there's still significant uncertainty arising from countries' sort of capacities to procure and roll out vaccination campaigns. So, until mass vaccination is achieved, we're still going to be relying on compliance with preventive behaviors, with hand washing, mask wearing, physical distancing to reduce transmission of the virus. The challenge is, though, that if individuals are forward-looking, their adoption of these behaviors and their assessment of the sort of expected costs and benefits are not necessarily going to be independent of the timelines for when vaccines become available, or their perceptions of when vaccines become available. So there are a number of theoretical pathways through which timeframes for vaccine availability could influence behaviors and perceptions. So the first is some sort of prevalence elastic behavior where, if there are delays in the rollout of vaccines, this leads to sort of increased risks of infection and increased perceived risks of infection, which could incentivize some sort of increased compliance with sort of recommended behaviors. On the other hand, from the psychology literature, there's this phenomenon of risk habituation, where prolonged exposure to infectious risks can lead perceived risks to become sort of detached from objective risks, and perceived risks could fall despite objective risks not changing or going up. And finally, there's this potential for fatalism, where prolonged exposure to infectious risk could create the sort of sense of inevitability in infection, which could have sort of perverse effects on adherence to preventive behaviors. But at present, a lot of this is how people respond is actually going to be sort of an empirical question, and this is very much the focus of this paper. So we have two objectives here. The first is to document levels and compliance with preventive behaviors in Brazil and South Africa. And second, we want to understand how individuals' risk perceptions and intended behaviors and support for various policies are influenced by information on the potential timeframes for availability of vaccine. And to do this, we sort of implement a large online experiment in Brazil and South Africa. And just to briefly highlight our findings, we find that compliance with preventive behaviors, or with all preventive behaviors, is far from universal and appears to be strongly correlated with perceived risks. We also find that information on the speed of a vaccine arrival does appear to impact risk perceptions and individuals' intentions to comply with certain preventive behaviors. We also find that the effects are not homogeneous. So those who are sort of more optimistic about the arrival of a vaccine are more responsive to the information treatments. All right, so in terms of the survey, we recruited about 6,000 individuals in Brazil and about 3,000 individuals in South Africa from an online panel in mid-July of 2020. We focused on these two settings as they are both countries that at the time had been hit hard by the COVID-19 epidemic. And they also critically both had been sites for COVID vaccine trials. And so there was likely to be sort of discussion of these issues in the press. So in our case, while the participants are sort of representative of national population on sort of like crude demographics like age and gender, we do find that there are significant differences by education, wealth, and sort of urban, rural than you might see in the populations at large. So the survey is structured in three components. We had a sort of baseline component that measured respondents' demographics, their sort of education, labor market participation, and then also a series of COVID-related knowledge, attitude, practice type questions, where in particular we looked at compliance with a set of recommended preventive behaviors in the prior week, as well as querying them on their perceived risks of infection. So following that section, participants were randomly assigned to either a control or one of two information treatments, where the one information treatment presented individuals with sort of optimistic information about when a vaccine might arrive, and the other slightly pessimistic information about when a vaccine might arrive. And immediately after that, we then queried the respondents about the outcomes that we're interested in, which I'll describe shortly. So the information treatments were essentially short videos that cut headings and headlines and clippings from the local and international press that either presented sort of positive views about vaccines that were being trialed and could be rolled out, or negative views. So the opening of the videos would present respondents with this sort of question of when will there be a coronavirus vaccine? And then in the case of the optimistic treatment, it highlighted, the sort of positive news stories, highlighting sort of early initial findings and promising early findings in trials and that sort of thing. And then focused on sort of efforts that were underway to grapple with the rolling out of the vaccine. While in the case of the pessimistic treatment, the stories that were highlighted sort of raised questions about the effectiveness of the vaccine for particular populations, and also dealt with the significant challenges that there would be in sort of deploying a vaccine at scale. And then finally, the last slide that was sort of the last frame that was presented to respondents posed the question again and provided some sort of interpretation of the headlines and news stories that they'd been shown previously. So the outcomes that we're interested in here are perceived risks, and in particular, we're thinking about sort of future risks. So we asked individuals to sort of rate on a scale from 0 to 10 their expected infection, the likelihood of infection in 12 months for themselves, and then also for a sort of average person in their population. And then we also queried individuals about what they thought the 10-year mortality rate would be for individuals who are sort of 60 and above. And then moving beyond risk, we're obviously interested in preventive behaviors. And so here we queried individuals sort of intended likelihood, again on a scale of 0 to 10, of either of avoiding non-essential shops or outings, wearing masks in public, and maintaining physical distancing. And this was done for 3 points of time into the future. So short term in 3 months, medium term in 6 months, and longer term in 12 months. And then finally, we also queried individuals about their support for various government policies, like the closure of schools, the closure of public transportation, the closure of bars and restaurants, making self-isolation mandatory, making mask wearing compulsory, and what fines should be if masking was not complied with. So we estimate our treatment effects with a simple regression of our outcomes on treatment assignment dummies and a set of controls. And we estimate these regressions for the specific outcomes that I've just walked through, and then a sort of weighted average index for each family of outcomes. All right, so in terms of the assessment of sort of compliance with preventive behaviors in the two settings, what we see is if you look at sort of behavior by behavior, compliance is fairly high. It's in the high 80s or low 90s. But if we look at compliance with all 5 behaviors, we see that it's only at around 65%. We haven't presented this here to save time, but we do find that compliance is higher in certain demographic groups. So it's higher amongst females, it's higher amongst older individuals, and more educated respondents. And then also critically, what we find is that compliance with these behaviors is strongly related to perceived risks of COVID infection. Okay, moving on to the information treatments. So starting with the effect of the vaccine arrival information on risk perception, what we see if we look at the optimistic treatment is that receiving this sort of optimistic information induces a decrease in the expected average risk of infection of about 0.16 points, which is something like a 6% of what the control group standard deviation. But it appears not to have effects on expected personal risk and the elder mortality rate. If we look at the pessimistic treatment, this here, receiving sort of information about, delays or sort of challenges with vaccine rollout, we see increases in perceived risk, both at the average level and at the personal level. And this is, the magnitudes are sort of similar at 5 to 6% of the control group standard deviation. And this also follows through to the joint index of our risk measures. We now look at the impact on intended compliance with preventive behaviors. So like I mentioned, we queried this on sort of 3 timeframes. And so if we start with the optimistic treatment, what we see is a reduction in the intended likelihood of maintaining physical distancing at the 3-month timeframe, and a similar reduction for masking in public. The effects are small and so don't follow through to the joint index. And then if we look forward, we do see effects on the effects persist on masking at 6 months and again at 12 months. If we look at the effects of the pessimistic treatment, we don't see significant effects in the sort of 3-month timeframe and 6-month timeframe. But at 12 months, we do see a significant increase in the intended likelihood of maintaining physical distancing. We don't see much when we look at the effect of these treatments on support for preventive policies. And then finally, we do look at sort of heterogeneous effects. Again, I haven't, to save space and time, haven't presented everything here. But in general, what we find is that individuals who have a sort of more positive or like slightly optimistic perceptions, either through having been less exposed to the virus itself or a lower perceived risk, are more responsive in particular to the optimistic treatment. And this again follows through to intentions to comply with preventive behaviors, where those who are sort of pre-treatment are more sort of optimistic about the world, are more swayed by the optimistic treatment. We don't see much heterogeneity by these sort of COVID risk measures when we look at support for the policies. But in the case of Brazil, we do see some sort of political role or political characteristics varying the effects of these policies, where those that report having voted for Bolsonaro are less likely to support the policies regardless of the information that they're shown.
1 minute left.
All right, so just to wrap up, we find that compliance is not particularly high with these behaviors in South Africa, but it is correlated with perceived risks. We find that in particular, pessimistic information increases perceived risk, but optimistic information has some risk, some impact on perceived risk, and some impact on intentions to comply with preventive behaviors. And this is more so the case for people who are pre-treatment are more optimistic. Obviously, there's sort of issues, some limitations in what can be interpreted with these sort of intended behavior measures. There's sort of issues of social desirability bias and present bias, given that we are sort of trying to get at behaviors which would only be taking place in the future. So some caveats apply. And so just to wrap up, we're still living in a world of significant uncertainty with regard to when vaccines are going to be rolled out. This is particularly the case for LMICs, where there are sort of significant issues of procurement, where many countries have not been able to sort of bilaterally secure a vaccine. And in the context of this uncertainty, individuals are sort of forming beliefs and expectations with regard to COVID and their own behaviors. And so we find that overly optimistic messages could potentially drive people to form lower risk perceptions and potentially lower compliance with preventive behaviors. And more so, the expectations that people are forming can serve as reference points. And there's some evidence that deviations of policy from these expectations can have impacts on compliance. So in some, I think our findings suggest that messaging relating to the rollout of vaccines going forward needs to be handled cautiously with an eye to impacts on behavior in the short run.
Thank you, Nicholas. You can stop sharing your screen, and our discussant, Alan Moscow, can start her comments right now. Go ahead, Alan.
Thank you. I don't have slides, so I'll just give them verbally. I really enjoyed reading this paper. I think it offers some really useful ways to think about communication related to uncertain information and the challenges from a policy standpoint that brings. The authors, like everyone in this session, did a nice job of working within the confines of what COVID-19 allowed us to do in the field. And I think in particular, focusing on low and middle income countries that are hard hit by COVID is very important. I would really love to see a repeat of this study now that we know so much more about the vaccine risks and effectiveness. Even though we don't know exactly what the rollout will look like, especially in countries like Brazil and South Africa, it would be very interesting to see what happens to people's responses to information like this now that the effectiveness is known and is so high. And touching on a point that Sue made in her comments, I think that since we know now that a vaccine will be available and will be highly effective, to think about how we can frame the information in terms of not only delaying COVID-19 infection, but increased adherence to preventive behaviors being a chance to avoid infection entirely, and sort of see if we can leverage risk aversion to our favor in that way. So I hope to offer some feedback on sort of one conceptual interpretation point, and then also some comments that I hope will strengthen the paper overall. So I think this paper really highlights the challenges of survey experiments, where small details related to the implementation of the survey experiment can have really important influence on the outcome and make it challenging to cleanly compare a particular construct. So I think the main sort of design comment that I have is that the pessimistic treatment in not shown in the slides, but in the appendix of the paper, there's more information given, in the headlines reported in the pessimistic treatment really focus more on the risks of vaccine side effects rather than the just delays in the timeline, versus the optimistic treatment, which focuses more on the speed of possible vaccine approval and availability. And so I think it would be really useful, given that, to discuss how this impacts the interpretation of your results, because comparing sort of a shorter time frame to a longer time frame is one thing, but comparing a faster delivery to a longer time frame or a more ambiguous time frame, plus discussion of potential risk involved with taking the vaccine itself is quite different. And I think it would be really useful to make some predictions about how this should impact the behaviors that we see, and in particular, people's expectation of their risk. So it could be that, you know, because these treatments aren't exactly symmetric in the constructs that are in them, that the pessimistic treatment really activates risk aversion, and that is why we see that's why we see in the results some increased risk, like the increased levels of expected risk. And then I think it would be also nice to do a little bit more on the measurement side, specifically because this is an online survey. There's a need to talk about who these people are, especially in a context like Brazil or South Africa, where there is high internet penetration and high access to smartphone use, but still very unequal. And a large proportion of the population that may be most at risk is also going to be least likely to access this type of online survey. So to say more about how these panels are constructed, beyond just how their demographics compare to the country, but also how is the recruitment happening? For example, do the recruitment ads and the surveys render well on smaller, cheaper smartphones that may be more ubiquitous among lower income segments of the population? Does the recruitment mention COVID specifically? Could it be that something in the recruitment screens in or screens out certain types of people? And then also on the issue of social desirability bias, I think it's still possibly a concern, and it would be nice in future work to consider doing some more work on social norms to try to circumvent that. I know there's some debate on, you know, whether list experiments or other types of things are really useful in eliciting this type of data. And so maybe that's not the route you want to take, but doing a little bit of work on what people expect others to be doing may also help triangulate how accurately they're reporting. And then I think a few smaller points about strengthening the paper. There's a lot, sorry, am I out of time?
You're out of time, but just close.
I'll send them by email. Thanks, this paper was great.
Thank you so much, Ellen, and thanks for keeping the time. We are a little bit behind, but let's get our next slides loaded up by Irina Sabat and her team to discuss battling the infodemics, health communication effectiveness during COVID-19. And for the audience, please use the question and answer box, and we can keep our questions going in that question and answer box. I'm a little worried that we will have the time we had hoped for at the end, so let's use the box. And go ahead, Irina, and present your talk.
Thank you very much. Hi, everyone. I'm Irina Sabat from Nova School of Business and Economics in Portugal. And this is a joint project with my 8 other co-authors from Bocconi University, Erasmus University Rotterdam, and the University of Hamburg. The motivation for this research was the following. At the start of the pandemic, the WHO published 5 basic protective measures to prevent the spread of coronavirus. Those included washing hands, keeping the social distance, avoiding touching face, avoiding hugging, kissing, and so on. And a high level of adherence to each of these protective measures could have been achieved only through changes in individual habits. But from the perspective of the individual, understanding the behavior and the purpose for changing this behavior is crucial. So while theoretical models of health behavior argue that individual risk perceptions are likely to be the motivating factors behind changes in people's behavior, experimental and empirical evidence supporting this claim are quite mixed, and especially given the setting of a pandemic. And many of these studies also ignore the formation of risk perceptions. So given this motivation, we posed the following research questions in this paper. So the first one that we want to answer is whether we can rely on individual risk perceptions during the pandemic as motivating factors for adherence to protective behaviors, whether eliciting changes in risk perceptions lead to changes in protective behaviors or intentions to alter protective behaviors. And we also want to know what is the role of the social context in the adoption of changes in behavior, again, in the context of the pandemic. So this is work in progress. All the results will be preliminary. So if you have any suggestions or comments, I will be very grateful for those. So our study is based on the following strands of literature. First, the theoretical background is presented by the main theoretical models of health behavior, like theory of reasoned actions, theory of protective behavior, which all share the common central construct that individual risk perceptions determine people's behavior. Then there's we did a review of studies and meta-analysis on influenza and SARS virus, which claimed that greater levels of perceived susceptibility or perceived severity of the disease or perceived efficacy of preventive measures are all important predictors of changes in behavior or adherence to recommended behaviors. Then, but these studies are mainly correlational. They use cross-sectional data. So then we reviewed the experimental studies, which claimed that, which found that heightening risk appraisals leads to changes in intentions and behavior, but the magnitude is smaller than that reported by these correlational studies. However, these experimental studies, they mostly target some specific health domains and do not address the setting of the pandemic. And yet another strand of literature related to our research is addresses self-interest versus prosocial behavior. And these studies are well represented when dealing with the topic of decision-making regarding vaccination. So this is the framework of where our research belongs. And now I will tell you how we did that. So we launched the survey, which is called European COVID survey. It includes 7 countries: Denmark, France, Germany, Italy, Portugal, the Netherlands, and the UK. We sampled 1,000 respondents, representative of each of these countries in terms of region, age, gender, and education. And in the first wave of the survey, we also sampled 500 extra respondents representative of Lombardy, because that region was especially hit by the COVID. And the field work was conducted in April. That was wave 1. And then we repeated these questions, this survey, every 2 months. But for this, for today, I only used the data from wave 1. And we conducted an information provision intervention within the survey. So the questions we asked related to this topic were, first of all, we asked people about their current adherence to preventive behavior. So we asked them during the last 4 weeks how, to what extent they adhere to the following activities. And we asked them for every activity. So for washing hands for at least 20 seconds, for avoiding hugging, kissing, handshakes, and so on. So for all 6 items. And the answer choices were no, yes a bit, yes quite strongly, yes fully. And we also asked them, all participants, about their risk perceptions. So we asked them to use a scale from 1 to 5 and report their likelihood of getting infected with the coronavirus and possible consequences of COVID-19, either to their health or to health of their family members or to the health of people in their communities. So we had 4 risk perceptions. This happened before the intervention was introduced. Then actually came the intervention. So we randomized people into 3 groups. The first one was the control group, which received a poster with these protective measures listed. So wash your hands, sneeze into your elbow, keep the distance, don't touch your face, and avoid contact. Then the second group was self-benefit group. So that's the same poster with 2 prompts, which said, reduce your risk of coronavirus infection. Remember that your actions impact your health. So here we made the emphasis on the self-benefit from following these actions. And then the societal benefit group, the third group, received the same poster with slightly different messages. So which said, help to reduce the spread of the coronavirus in your community. Remember that your actions impact not only your health, but also the health of vulnerable others. And we also added these 2 shades of elderly people in there. And we added 2 attention checks. So if the respondent didn't, the respondents were asked to say what was the bottom line of the poster. If they did not remember, they were showed the poster again and checked again. And if they failed the second attention check, they were removed from the analysis. And the outcomes that we measured, so after the intervention was performed, we asked them their intention to increase the adherence to basic protective measures. So we asked them, do you intend to adhere to the protective measures? And then the answer choices were again, no, yes, a bit, yes, quite strongly, yes, fully. Here we asked them not item by item, so not separately for each of the protective measures, but generally about the poster, generally about all the items. And we also measured again the risk perceptions so we asked the same block of question to all participants except for the control group. So we checked whether, we wanted to check later whether the poster would also impact their risk perception, would trigger changes in their risk perceptions. So the idea is that we have a prompt emphasizing either personal or societal benefit. This is the mediation module in our research. And then this prompt has a direct effect, providing the information, which may change the intention to adhere to preventive behaviors in future. And there might be an indirect effect through the perceived severity of COVID-19. So this is what we want to see if it's the case. And thus our hypotheses are the following. First of all, we expected that people from the self-benefit condition would decrease their risk perceptions regarding their own health, because maybe probably that would go through the self-efficacy channel. And again, compared to the control group, people from self-benefit condition would are expected to have a higher intention to change their behavior, so adhere to target behavior to a greater extent than the control group participants. That would happen because of both channels, so because of they know information how to protect themselves, and because they also decrease their risk perceptions. And then people from the societal benefit condition were expected to increase their risk perceptions regarding with respect to the control group, and also increase their report higher intention to change their behavior. So the econometric specification was the following. We ran a bunch of ordered logit regressions. Here, the intended behavior as a proxy for future behavior. Intended behavior was the main dependent variable, and it took values from 1 to 4. So from no adherence to full adherence. Then the main independent variable was the treatment condition, which was either the control group, which is the baseline, or first or second treatment groups. And then a vector of regressors included the age group, gender, education, income level, risk aversion, which was elicited through the lottery questions, the vulnerable household member dummy, then trust in the information from the WHO, Hofstadter's individualism score for each country, diagnosis of COVID-19 among a person's contact dummy, then risk perceptions and interaction between the treatment and the risk perceptions, and country dummies. And here are the preliminary results. So this table shows the difference in means across the treatment arms. So this is for the pooled data. Here we can say that the randomization went well. There were no significant differences in the pre-treatment variables. We had around 2,500 participants in each of the I also forgot to say that we had this health risk attitude score as yet another regressor, which shows the how risky people are with respect to their own health. Then these are the results for the across the treatment arms. This is intended adherence to preventive behavior in each of the treatment arms. So the left panel shows the distribution of answers within each treatment arm. And as we may see in each of these, in each of the groups, the majority of people answered that they would adhere to the highest extent. But this result, more people chose this option in 2 treatment groups compared to the control group. On the right panel, I plotted mean intended adherence. So the blue bar is the mean behavior pre-treatment, so current behavior, and the red bar is the mean intention to behave. So for the control group, there is a tiny difference, which is due to the rounding, since the pre-treatment variable was asked for each item of the protective behaviors, and the post-treatment was asked for the whole bunch, for the whole poster. So that's why the difference that's where the difference comes from. But if you look at the self-benefit condition and societal benefit condition, you may see that mean answers differ pre and post-treatment. And now, if we, then I ran the, since the outcome variable, as you could see, was not normally distributed, I ran the Kruskal-Wallis test as a non-parametric alternative to one-way ANOVA. This test determined whether the medians of the groups were different, and it showed that yes, they were different. But since this test is an omnibus test, it doesn't tell us which groups are which groups actually differ. So there's a need to conduct post hoc tests based on family-wise error rate, and this is what I do. So after next, I ran a bunch of logistic regressions, and I did the Bonferroni adjustment after each of them. So these are the results. This is the results for the logistic regression for intended behavior outcome, and here odds ratios are reported. So model with no risks means that I did not include the perceived risk. Model with risk 1 means that the risk of catching coronavirus was included, and the interaction between the treatment and this risk. Then risk 2 is the risk of risk of consequences of COVID-19 to one's own health. Risk 3 is the risk to family to the health of family members, and risk 4 to the risk to the community members. So these results show that both the self-benefit and societal benefit conditions, the results where the estimates were significant. So the odds ratios. So these interventions increase the odds ratios of reporting the higher intended behavior than people in the control group, so in the base group. However, if we look at the intervention, if we look at the interaction with risks, we did not, contrary to our expectation, to our hypothesis, there were no significant results. So only high perceived risk was significant, but no interaction, none of the interaction terms was. However, what I do not report here, I don't report the whole table of the results, but we found out that all age categories, all education levels, all high income levels, all trust in the WHO, high levels of trust in the WHO, they were all significant predictors of reporting the higher adherence. What was interesting, that having a vulnerable member in the household was not significant in any of these models. Then we also tested a bunch of a bunch of interactions to see if there were heterogeneous effects with respect to gender, education, income level, age. So again, what was interesting that there were no heterogeneous effects with respect to age groups, but we did find heterogeneous effects with respect to gender. So as you may see here, again, both interventions were significant. And we can see that the interaction between treatment and gender is also significant in all models. But again, here the odds ratios are reported and they are below 1, which means that the probability of the outcome is lower in this group, so for males. And I also plotted the predictive margins of this interaction term between treatment and gender. And you may see that for every treatment condition, females have a higher odds ratio, higher probability of reporting higher adherence. So for all outcome, for higher adherence, women are more likely to report it, and they are less likely to report low adherence compared to males. And another interesting finding is that we spotted a significant interaction between the societal benefit intervention, societal benefit message, and high education level. So here is the last row in this table. So again, the societal emphasizing the societal benefit condition seems to seems to have a heterogeneous effect on this high education level. So increase the odds of reporting higher intention to behave for highly educated individuals. And finally, this pairwise comparison that we did using the Bonferroni adjustment for all models showed that there is significant difference between the self-benefit condition versus control condition and societal benefit condition versus control condition. But we did not find, but we didn't find a significant difference between the societal benefit versus self-benefit condition. All these values were, p-values were insignificant. So we cannot claim that the societal benefit condition works better than the self-benefit condition. And so just to wrap up, our results, preliminary results, as I said, they suggest that framing of public health, the framing emphasizing either self or societal benefit of complying with protective behaviors is an effective way of increasing the probability of future compliance. Messages emphasizing pro-social behavior increase the odds of the intention to behave significantly more than did the prompt emphasizing either the self-benefit or no benefit, so the control group. We also hypothesized that perceived risks would be the mediation channel of the impact, but this did not seem to be the case. It didn't show up to work. So the exact channel of influence remains to be identified. And we found out that the effects of both interventions were actually lower for men than for women. And societal benefit showed significant interaction with the highest education level. Of course, this paper has limitations, and especially since we use the intention to behave as a proxy for future behavior. But what we plan to do next is to track whether real changes in behavior occurred over time for those people who continue participating in our survey. So in all 4 waves so far. And also, since the randomization went at the level of the country, there's also a possibility that it's better to do the analysis of for each country separately and see what each shows. Maybe the pool data is not the best way to see what's going on in there. So that's all from me. Thank you for your attention, and I'll be very grateful for your comments.
Thanks, Irina. Our discussant is Matthew Way from the London School of Hygiene Tropical Medicine. Matthew, can you share your screen? And please keep using the question and answer box.
Yeah, so as is the start of every good talk, can you see my screen okay?
Yes.
Excellent, thank you very much. So hi, hello from a fully locked down London. I'm a health economist, and for the last 9 months or so, I've been working on infectious disease modelling and health economics around COVID. Thanks, Irina, for sharing your full draft with me before Christmas. It was a good festive reading, a really enjoyable paper. I think you've exploited I think all the papers in this session have exploited a unique opportunity, looking at how risk perceptions are shaped by something that's totally unprecedented, and exploring these interesting dynamics about individual and social determinants of personal behaviour. Yeah, it's really cool. Irina, you've left us on this Netflix-style cliffhanger where you've got 3 more rounds of data to analyse. You've also got your self-reported adherence measures, which I think is going to be a really nice addition when you can fit it in. I really think your negative finding, or sort of negative finding, from your mediation analysis is valuable in its own right, as you've alluded to there. Okay, these are just to recap the research questions and the kind of the conceptual framework about whether risk perceptions mediate the relationship between an experimental prompt emphasizing personal or social benefit, if they have any impact on intention to adhere to protective behaviors, the extent to which we're in danger or not, we perceive whether we're in danger or not influences our intention to behave or behave in fact. Okay, so first of all, the survey data collection, heady days, 2nd of April to the 15th of April 2020, just in the UK. I went back and looked at headlines just over this 2-week period. We start with, in the UK, the first COVID death in a hospital, lots of discussion about testing, discussions about clinical pathways of what's going to happen if intensive care units fill up. The Prime Minister goes to intensive care. Someone else is in charge, and the lockdown could last until June. You know, such a range of, I guess, events that are happening just over the 2 weeks where the survey is being conducted, let alone with your remaining 3 rounds. As I said, there's lots more exciting stuff to come here. I was a bit unclear, presumably because you didn't present the results, what your partial panel structure was. It wasn't quite clear what size it was, what power it was, what you were trying to detect across those different things. And like I said, that cliffhanger is going to be really interesting stuff. I'm not going to go back over your key findings because you presented them really clearly. So I'm just going to stick to a few kind of discussion points. The 4 hypotheses presented, they're all kind of really interesting, they're all really testable. I didn't think they were linked that much to the lit review. So one kind of specific example is you hypothesize that people will be more optimistic about their own health compared to others, which I think is fair and valid. There wasn't much on that in the quite comprehensive lit review you did around particularly flu pandemics. You kind of flip back and forth with your language in the paper, which I recognize that I've seen and nobody else has. That intention to behavior, you know, is sometimes mentioned as a reasonable predictor of behavior. Sometimes it's a good predictor, sometimes it's a weak predictor. I think the language around that is very tricky because it varies very much by context. This is all going to go away when you analyze your self-reported adherence, you know, given biases around people's self-report. You also label you dichotomize your 4-level variable into high and low adherence, or high and low intention to adherence. I think the high adherence group is perhaps stretching it a touch, but again, this will go away as you word things differently. The sample size, it wasn't hugely clear how many numbers and how many people you dropped. So there was kind of mentioned 7,500. I think in the results, it said 7,590. I was trying to look at how many outliers you dropped. You did some tests about people who did or didn't adhere to certain conditions you put on. And in particular, it'd be really interesting to hear about your loss to follow-up and the sample composition of the later waves that you have. I say that last point because we've had a bit of issue of keeping people engaged with these repeated survey panels. We get a really skewed sample 3rd or 4th wave, particularly about COVID more so than other health issues. I think one thing you could touch a bit on more is that the salience of this pandemic is incredibly different to these previous epidemics. So you cite in your really nice lit review generally high income country work about influenza pandemics, either real or kind of theoretical. Prosociality, I think, has been a much bigger part of the COVID response and the COVID control measures, necessarily so. And therefore, I agree with you that a country level disaggregation is really important. Baseline prosociality is going to vary across countries. I think the response and the messaging varies across country. I say from, yes, as I say, a very locked down London. And the timing, you know, how the pandemic is in its wave, and the survey wave is going to be different. You could be surveying people at different times, and different salience of the pandemic in the country could be different. You noted in your talk that the results from previous experimental studies were small. It'd be interesting to see how that compares with your odds ratios of, you know, doubling intention to adhere. I think that's quite big. And then finally, something maybe to think about for your panel is that your control group are all showing WHO information at the end. Is that going to influence how they respond to your next survey, or is this stuff that they're just being barraged with as people go about their daily lives at the moment? Okay, a couple of other points.
Can you wrap up, please?
Yeah, sure. I will. I'll send the slides over. I'm just going to touch on that. I presume the intention was to show kind of some initial interesting results, which I think you've done really well, and then adapt to include these panel and self-reported measures. And I wish you good luck for that. So thanks very much.
Great, thank you, Matthew. Our final presentation is by Bruno Bentillo from the University of Marseille, and he'll be presenting his work on nudging for lockdown. And Bruno, you're on mute, by the way, and you're on slide mode, not presentation mode, but we can see slides.
Okay, so you can see, okay, I've got to probably, now you can see them.
You can see slides, but not on presentation mode. Now we can see presentation mode. Go ahead.
Okay, sorry for the delay. So this research is part of a larger research program dedicated to the behavioral economics of COVID prophylactic measures. And here we focus on the tentative of nudging. The research is made within 3 universities, 2 in the south of France, Montpellier and Marseille, and 1 in Strasbourg. And some of my co-authors are with me on this session. So in short, because I know that it's the end of the session, so what this paper has, we test a social influence nudge. I will define that, which is kind of feedback communication for lockdown, to have an idea of a potential effectiveness of a nudging strategy to push compliance to lockdown. In relation with some targeted population. We see what kind of population we can target, in fact. We also investigate the role of some behavioral determinants that could channel the effectiveness of such nudge. We aim at having a better understanding of the psychoeconomic mechanisms which are behind a nudge when a nudge works. Nevertheless, this paper is not really about actual behavior. This is not a real reality of a real policy, because we don't really observe actual behavior, but only intentions to comply. So we would like to present this paper as maybe a proof of concept, a feasibility study of a nudge strategy. What was the literature, the background literature? In fact, when we decide when we prepare the survey on the RCT, nothing was published on the relationship between lockdown and nudge. It has been published since March. Some papers have already been published, but at the time when we prepare the research, nothing was studied. So it was published. So our background was the social comparison nudge in the domain of energy conservation. The principle of this nudge is to give feedback on energy use by neighbors to push them, to push subjects to have a better conservation behavior. And the literature on this domain shows that generally it works. So transposed in the field of lockdown compliance, this principle consists in informing respondents about London compliance of their proximate counterparts. To give feedback information, we decide on the idea was to use the term which were used by the media to discuss lockdown compliance, and some this media, this TV the channels which 24 channels on information use some information, use some data coming from Covet, which is a website which was giving information on the road traffic at various dates, and it was a possible. It gives a possibility to observe the compliance to lockdown in different regions in France through road traffic information. So we start the information that we give to the subject by this kind of sentence. The application Covet identifies motorist trips in the regions and compare them to the normal pre-crisis. And after this sentence, we decide to randomize the information given to the subject in two groups. The first group with a positive information, so it could be an optimistic information about compliance. We use the information which was given which was available for the 3rd of April. On Covet observed a greatly reduced traffic was recorded for Friday in Normandy, with barely 40% of the flow of usual trips, demonstrating a scrupulous respect of the confinement. On the other group, which was treated negatively or pessimistically, we use the information on the 17th of April. An almost normal traffic was recorded for a Friday in Normandy, showing a certain looseness for confinement. So we have two groups treated differently by a feedback communication. After that, we had a recall question, which was not the main questions. What do you think is the level of confinement compliance today in your regions? On the second questions, which was following just after, of course, asked to all groups, in the event of a new confinement made necessary by a rebound in the epidemics, would you say that you will scrupulously respect the government instruction of confinements? Place your answer on a scale to 0 to 10. Okay, so it was, of course, this variable on which we expect the effect of the nudge. Okay, there is a slide on for French because, of course, the survey was made in France. In the survey, we also collect a lot of information. Of course, we collect information about the health of the agents, the socioeconomic variables, age and gender, of course. And we also elicited a series of individual and social preference, both with incentivized experiment and with stated preference method. In the table, you have different dimensions on which we revealed preference, both by self-reported questions and also by incentivized task, as we do generally in behavioral economics. What are the results? First, the recruitment. We use a survey institute, and they recruit for us a representative population of the French population, and we propose them the online questionnaire on the tasks that I've just presented. Just some statistic about the targeted population. So we are more or less representative in terms of gender, age, and the composition of the population by regions. We are almost representative of the population in terms of political positions, except we don't have enough far-right people, which is a classical problem in surveys. Main dependent variable was distributed as you can see in the slide. So of course, there is a distribution which was very asymmetric and at the right of the scale. So we decide to make a binary dependent variable. And we select only 9 and 10 as to do the analysis, but we have some robustness using a Tobit or alternative curves. So what are the results? First, we do not succeed to create a difference by the social comparison need in the whole France. There is no difference between the population treated positively or negatively. But maybe you have noticed that we use some data about road traffic information, which were located for Normandy. And we use Normandy just because it was the region which presented the highest contrast between two dates in terms of traffic information. So, so if we consider now only the Normandy regions, we observe a difference between the population treated positively or negatively. This difference is significant. If we go to the neighboring departments at the neighbor of Normandy, we don't have any effect. Of course, I already commented the fact that there is no effect in Normandy. We also tested the relationship between the revealed preference by the main dependent variable. We do not have a lot of predictive power for insensitivist task, although there is a high relationship, good correlation with self-reported preference. another result that we have, if we now focus on the population of Normandy, on which the nudge worked, and if we test all the interactions possible with the behavioral economic tools that we have in the survey, we detect a positive interaction, a significant interaction between the public good game, which was incentivized, and the nudge. And what we have, in fact, is that the public good game is made to detect free rider versus cooperative agents. And what we have is that in Normandy, the nudge work better, or effectively work only on free riders. So those who are detected as non-cooperative are, by the public good game, are in fact influenced by the nudge, the social comparison nudge. The last non-result, if you remember, we asked a question about what do you think is the level of lockdown compliance today in your regions? And we could expect an impact of the nudge, so the positive feedback, on this belief. And we did not find this kind of effect. So the nudge mechanisms does not pass through a revision of belief of the agent. It's something else. And I will try to give an explanation later in another slide. So we have 3 non-results and 2 results. The non-results, social comparison nudge, speaking about motorists in Normandy, does not impact outside Normandy. The second non-result, preference revealed by incentivized tools have with significant predictive power. And the nudge does not pass through a revision of beliefs. However, we have some positive results. The first positive result is that tools based on self-reported preference do predict anticipated compliance in case of rebound. And the nudge works in Normandy, mainly because it convinces the free riders. Okay, so what are the limitations of this research? We do not observe real behavior, but intention to respect in case of future rebound in the epidemics. I already give some information about that. In fact, it's a limitation because in reality, we did not expect that the salience of Normandy will be so strong. As I said, we select Normandy because it was the regions offering the highest contrast in March in terms of road traffic on respect of confinement between 2 dates. But we did not expect that this effect, the salience of Normandy will be so strong, and that the nudge worked only in Normandy. And by consequence, the effective positive impact of the nudge is restricted to a small sample, and it's a weak sample to really be able to study all the psychoeconomic determinants that we plan to study. So some non-results maybe are not real non-results. They could be only a lack of power, of statistical power in the analysis. What are the takeaway message of this study? If you use a if you intend to, as a policymaker, intend to use a social comparison nudge, you should talk about proximate neighbors for facilitating the identification process. And you should talk to free riders in priority, because these are the populations which are convinced or influenced by the nudge. In fact, in the public good game, the mechanisms behind the public good game is that free riders lack of confidence in over the behavior, because if they give money in the if they give money, in principle they should have a better return. But so free riders, when they don't give money in the public good games, the problem is that they lack confidence in the others. So what we have is maybe that the nudge modify not really the belief of what on the behavior of others, but the nudge modified the confidence that you can have on the behavior of others, the planned behavior of others. And if I come back to the literature in psychology, it's very close to the theory of planned behavior that in which we can we will have more insight to be sure that we can really rely on this theoretical background. Thank you. Maybe I was a little bit short, but.
Thank you, Bruno. We really appreciate that. And to our audience, we have about 10 minutes left for your questions and answers in the questions and answer box. Bruno, you can stop sharing. And our discussant will be Leontine Goldzal from the EdHec Business School.
For some reasons, it doesn't. Well, anyway, it doesn't show this properly. Anyway, sorry about this. Thank you, Bruno, for this presentation. So I will just start with a small slide summarizing maybe the experiment that was just presented to us. In order to continue with my different comments. So basically what we have in this experiment is two different nudges. And one is basically giving people an information of high compliance with lockdown instruction in a specific region, which is Normandy. And the other nudge is low compliance with the lockdown instruction in Normandy. And what is important here is that they were using data from an app relying on car utilization basically at a certain date. And the high compliance was measured on the 3rd of April and the low compliance was measured on the 17th of April. So people in France were randomized between those two groups and they were asked about their future compliance with a lockdown in case of a second wave, which we definitely had. And then in their survey experiments, they were measuring economic preferences. So it's very nice because they have a good collection of economic preferences from risk preference, social preferences, mindfulness, etc. And they were using both incentivized tasks and stated preference measurements. Right, so I think it's a nice study, but it would be a little bit improved into a number of directions. I think it would be nice to maybe use more what the nudge concepts is. I guess it relies obviously on the libertarian paternalism. Sorry for this slide, it's really annoying. Libertarian paternalism concepts where people are supposed to have still freedom of choice but we are still influenced by the government. So I think it's also nice to use these concepts if you were presenting your intervention as a nudge. In addition to this, I think it should be discussed a bit more extensively what you are actually using in the intervention, whether it's a nudge or information provision, because information provision is actually what you're doing, right? You're giving more information to individuals to what they initially had, as a nudge is supposed to be just a change in the architecture of the choice. And what you're doing here is you're doing both at the same time, and the social norm effect that you expected is the nudge part, but you're also providing new information to people. So I'm not so sure you can definitely call it only a nudge. In addition, so you mentioned this in your paper and in the discussion, so you expect that people will see high compliance with lockdown as a social norm, but like how much do we need to see people comply with some guidelines in order to say, well, that's the norm, so there's a cost to me in order, if I deviate from the norm, it will be costly to me, so this is why I just like adopt the same behaviors as others. And I was wondering if you had some insights of like how much, well, you know, is it 80%? Does like 50% of the population need to adopt a behavior for me to feel this cost and then comply with the same behavior? I think if you, because you have a lot of different economic preference measures and you're using nudge, I think it will be also nice to have a more global idea of how those different determinants affect compliance. And in addition to economic preferences, I think it's, I mean, obviously, like you have all these behaviors that you have this in mind, but it's also possible that you have some, you know, like some expectations about like immunity, whether people are immune, whether they go outside because they're immune, or it's just because people respect compliance or not. Like there's a lot of also the other determinants, such as like whether people are at risk, how much exposure do they have to the virus, whether they have a pre-existing condition. So it would be nice to have much more like extended frameworks, including all those individual determinants presented in the paper. And yeah, so anyway, so I think my second comment focuses more on the nudge itself.
One more minute.
And
one more minute.
Yeah, sorry, I'm going to finish with this. So I think it's also something that applies to some other presentations that I saw today about the fact that the sender matters. So it's important to know what do subjects know? Like, do they know who's talking to them? Do they know this app? Like, do they believe this is something important? Is it the institution talking to them, the government, some health authorities? Or so I think the sender matter, and I would like to know who they think is talking to them, basically. And I would just finish with this. So, you know, there were this 2 weeks difference between the low and high compliance nudges. And I think it's important because a lot of things happened in France between those two dates. It was the end of the lockdown, and exactly in the middle of those two dates, the president actually said on TV that the lockdown will stop on the 11th of May. So I was wondering whether you can provide us with some convincing argument saying that it's not an effect of time, date, but it's actually an effect of what others are doing. And I would just finish with this. It's really the effect of one nudge versus another. It's not against the control group. So in the framing of the results, I think it will be important to remember that the other group actually were nudged as well, and were nudged in the way that they was told that there is low compliance in Normandy. Yeah, sorry for being a little bit long, and I will obviously send the slides to you with the other comments I wrote. Thank you very much.
Thank you, Leontine. We have 2 minutes left, and we have an open question and answer box for the audience and for our presenters and panelists to try to send in some comments and wrap up on the key things. So please use that right now. For all of you in the audience, this session has been recorded, and the American Economics Association will be telling us how to get access to it. I don't have time for the presenters to individually thank the discussants. I want to thank our discussants as well as thanking the presenters. My takeaways are really very operational. I've learned so much about how the individually incentive compatible version of how to behave is malleable, and the results we got from Gabriella showed that there is a large internal willingness to pay that is motivating, yet there's still an externality. I don't think any of us would actually think it would be acceptable to pay people to behave because of the ability to game the system and hold out for payments. I think that would be a real problem. But in order to change people's perceived risk and perceived benefit, we do have informational tools that are availability. And Nicholas, Irina, and Bruno told us a lot about how to design those tools, how to design our perception of how optimistic to be about the vaccine, how to design our perception about the social consequences to our loved ones and family. Are we doing this to benefit ourselves or others? So I think we've got a lot to take home. I wanted to thank you, and I hope this field marches forward. We really need these results out and shared, and I look forward to seeing them come to light soon. So goodbye, everybody. Thank you so much for coming. Stay safe, and see you live in real life, hopefully soon.
Thank you, everyone.
Thank you.
Bye.